So students, let us now discuss miscellaneous disorders of the nose and paranasal sinuses. These are small MCQs which come in the exam. So let's discuss them quickly. Okay. So number one is the nasal myiasis. So what do I mean by nasal myiasis? Nasal myiasis means maggots in nose. Now these maggots, they are larvae of trichomia. So generally patients who have chronic rhinosinusitis, who have a lot of nasal discharge and their personal hygiene is very poor. So what happens, this fly, it comes and it lays eggs in the nose, and then these eggs, they hatch into the larvae. Okay, right? So what is the treatment for this nasal myiasis? The treatment is 10% chloroform. Why 10% chloroform? You see, these larvae, if you shine the light, they will go and hide inside the dark sinus cavities, right? So if you shine the light, they will hide, they will not be visible to you. You want to see them and you have to remove them under vision. Okay, so you cannot remove them in any other way. You have to put 10% chloroform, they anesthetize these larvae, and then you can remove them under vision by the headlight, or you can even do an endoscopy, and if there are some larvae, you can remove them by under endoscopic vision also. All right. Next is foreign body in the nose. Now the foreign body is very common in case of children. So if there is a child, now he is likely to be playing, and while playing, especially in the age group of 1 to 4 years, this is very common. The child is playing and is trying to explore everything, so he can put a small foreign body and put it in the nose. Okay, so this foreign body is very common in children. It presents in the children usually, and this child will not tell anyone. Okay, unless it's trying, he's having pain, he'll not tell anyone. So he'll come to you late. If he comes to you late, this patient will have unilateral nasal discharge. Remember, 1 to 4 year child cannot complain about obstruction, but there will be unilateral nasal discharge, and this discharge may be a mucopurulent discharge, or it can be a blood stain discharge. And that is your MCQ question over here. Let's say you have a question, a 4-year child presents with unilateral mucopurulent discharge. So whenever the said word is child and unilateral, the first DD that you have to think is foreign body in the nose. Okay, so that is the first DD you have to think. And how can we remove this foreign body? We can simply remove this foreign body by passing a probe behind this foreign body and then engaging the probe and bringing it out. Okay, so removal is quite easy. Only thing you have to do is to manage the child, because the child is usually scared, and if the foreign body is old, it may be adhered to the wall, so while mobilizing it may be painful. All right, now over here there is important foreign body that is asked in the exam, that is a button battery. Now this button battery, this is found in toys, some toys. It is found in some small remotes. It is found in hearing aids. And these are the things which are sometimes left around in the house. Hearing aids may be left around. The child may pick them up. He's playing some of the toys. These toys, they can break. And these button batteries, they come out. Now, if the child put these small button batteries in the nose, what will happen? These are alkaline batteries. Right? Now, because these are alkaline batteries, when the battery comes in contact with the nasal secretion, it leaks and the alkali comes out, it can cause liquefactive necrosis. Okay, so it can cause liquefactive necrosis of the septum, of the surrounding tissue. Not only it will be painful, it will also leave a permanent damage to the patient nose or the septum. Right. So for this button battery, if a patient presents to you with a button battery, what you have to do is you have to try and remove it as soon as possible. Okay. Immediately try to remove it. Do not wait for the specialist doctor to come, or do not tell the patient, okay, you come in the morning or you have to go to such and such hospital. Do not refer the patient. try to remove. The first step that you can do is that you try to remove it yourself. You are the doctor in the emergency. Okay, the patient has presented to you first. The best treatment is that you try to remove it ASAP, because at this time, suppose the patient has put this foreign body an hour back, the leak has not taken place, the foreign body is not adhered to the mucosa or the turbinates, so you can easily remove it. Once the leak takes place, there will be liquefactive necrosis around the battery, and now the battery will be adherent to the bed, to the floor of the nose or the inferior turbinate or the septum, and then it will become very difficult, and also the damage has already taken place. Okay, so the best treatment is remove the battery as soon as possible. All right, next is the nasal bone fracture. So let us discuss a few of the facial traumas, and nasal bone fracture is the first one. This is the most common facial bone to undergo fracture. Okay, most common facial bone. Why? Because of the nose projection. So this is the most commonly bone that will get fractured whenever there is a blunt injury to the face. Now, this nasal bone fracture, it can be of two types. You see, the two bones, they are aligned to each other like this. Now, if there is a fracture, two things that can happen. This can lead to a open book fracture like this. Okay, so a trauma can lead to opening of this, or it can lead to a collapse. So that's known as closed book, right? So we can have a nasal bone fracture that can be a open book fracture, okay, or it can be a closed book fracture, right? Now the open book fracture as well as the closed book fracture, they can give rise to a angulated nose. So the nose may become angulated. The external nose I'm talking about, it can become angulated or it can be depressed, right? Now let us look in this X-ray over here. What do we see in this X-ray? We can see over here that there is a bony fracture, right? So this is the bony fracture. You can see that the nasal bone is fractured and there is a level which is up and down. Now remember, this is another X-ray. You can see that there is a bony fracture over here, right? Now main question that is asked in the exam is, how will you manage a case of nasal bone fracture? Okay, so management is very, very important. These X-rays are being given these days in the clinical questions and management is asked. Nasal bone fracture is a common presentation in ENT. Remember, common topics will be commonly asked, okay, and you have to give the common answer. Unless you remember these common things, learning rare things will not help you pass the exam or treat your patients. All right, so clinical skills, you remember there is a saying that the rare things will be rarely seen and they will be rarely asked in the exams. And if you remember only the rare things, you will rarely pass in the exam. So let's focus. This is a very important topic, repeatedly asked in the exam. Now management, how will you manage a case of nasal bone fracture? Now nasal bone fracture, you can see it can cause two types of problem. How will the patient present? Patient can have, number one, external deformity. So I will call it as cosmetic deformity. He has a cosmetic problem. Number two, patient has a internal septum deviation also. So nasal bone fracture can also cause a septum deviation. Now there is a functional deformity, that means he is not able to breathe, obstruction. Okay, so if there is a nasal obstruction, you have to take care of that also. So what will you do? You see, if there is a functional obstruction because of the fracture or because of the division, then obviously you have to operate on this patient. The cosmetic deformity, if patient however has only cosmetic deformity, the choice is given to the patient whether the patient wants to get operated or not. If the patient says that I am looking fine, this nose, this much angulation is good enough for me, I don't mind it, then there is no need to force this patient for undergoing any further treatment. Okay, if only cosmetic treatment is there, remember always give the option to the patient. Okay, if the functional deformity is also there, then you have to counsel the patient that he will have more problems in the future and it is better to get this operated now. All right. Okay, now what treatment will you offer? Now the nasal bone fracture reduction, the best treatment is closed reduction. So without giving any incision, you give a closed reduction. Okay, this is done with the help of Ash and Welsham's forceps. The nasal bones are mobilized and the fracture is reduced. So that's a closed reduction. Now this closed reduction is followed by external nasal splint application. So we apply external nasal splint. So you can say we are giving a external fixation. Right? Now the question is, when will you do closed reduction? That is the thing. When will you do closed reduction? Now remember, the best time to do this closed reduction is either immediately. Now what do I mean by immediately? Immediately means, less than 24 hours. Why less than 24 hours? That is before development of edema. Okay, that is before development of edema. You see what happens? If the edema develops around the fracture, then you cannot guess the amount of cosmetic deformity or the amount of correction needed. Now in that case, if you mobilize the bone, the cosmetic result will be poor. So in edema, we will not reduce this nasal bone. We will reduce it before development of edema. Now that is generally takes around 24 hours, but I have seen patients on whom the edema is within 2 hours or within 6 hours. So once the edema is developed, we will not reduce it. Okay, so before development of edema, or you can say immediately, or you can say 24 hours. Now patient usually does not present in your emergency immediately after the injury. Why? Because these patients, if it's a road traffic accident patient, he will have some other abdominal injuries also, head injury also. So he'll go to the emergency, the neurosurgeon, the general surgeon will see this patient, they might operate this patient or they might clear, and then the patient comes to you. So most of the times when the patient comes for an ENT consult for a nasal bone fracture, the golden time period for, before the development of edema has passed. All right. So when can you reduce? You can reduce then after edema subsides. Okay. So edema generally subsides in 3 to 5 days. So generally around, 5 to 7 days, that is the best time. Okay. That is the best time to reduce this fracture. Okay. So somebody asks you a question, what is the best time to reduce the nasal bone fracture? You should give your answer as 5 to 7 days, because this period immediately is unsure. All right, it can be 2 hours, it can be 6 hours, it can be 12 hours. It is usually less than 24 hours, and usually the patient will not present to you in this phase. So the best time to reduce is 5 to 7 days. By the time patient presents after injury, there is edema. So give him medicines for pain relief and tell him to come after 5 to 7 days. Okay, for how many days you can reduce? So let's say the patient does not come to you after 7 days. He goes home, he goes to his village. So when can he come back for fracture reductions? Remember, from 5 to 7 days, you can wait to 2 to 3 weeks after injury. Why? You see, 2 weeks in children, that means 14 days in children and 3 weeks in adults. What will happen? The bone will fuse. There will be a callus formation. So within 2 to 3 weeks, there will be a callus formation. Now the bone will fuse in the deformed position. So you cannot reduce the fracture now. You have to remember this thing, that once the bone has fused in the deformed position, now you cannot simply mobilize the bone. All right. Now you have to cut the bone to mobilize it. Okay. So now what will you do after 3 weeks? So let's say a patient has presented to us after 3 weeks. So what can we do? Now we will ask the patient to wait for 3 months. Okay, so this patient has presented after 3 weeks. So what will you ask? We'll ask the patient to wait for 3 months. Why? Why 3 months? You see, this bone has fused, but it is a soft callus bone. Now, if I try to cut this bone, it will have multiple fractures. All right. So for me, this is not the appropriate time to operate on this patient. I'll ask the patient to wait for 3 months, and after 3 months, I will do an internal reduction. That means I have to cut the bone, then only I can mobilize it. So when you cut the bone internally, the nasal bone, when you mobilize it, when you reshape it, then that is known as rhinoplasty. Remember, surgery of external nasal architecture to improve the shape of the nose. So you do rhinoplasty after 3 months, right? So that is how we manage a case of nasal bone fracture. Now let's look at this question. You can see this question was asked recently in FMG August 2020 exam. So a boy fell while playing, okay, and presents with deviated nose. So it has said there is an external deformity, there is a deviated nose. The septum, however, was found to be normal. So you see, only the patient has cosmetic deformity. Following is the X-ray finding of the patient. So you can see that this is the X-ray finding, and when we look carefully, you can see that there is a small fracture over here. The bone is displaced. So what is the next step in management? Septorhinoplasty. We have discussed septorhinoplasty is done after 3 months, and septum is normal, so there is no use of doing a septoplasty. Okay, open reduction means rhinoplasty itself. Closed reduction after edema subsides in 7 days. That is the right answer as we discussed. Okay, closed reduction and swelling will decrease automatically. Yes, the swelling will decrease, but your reduction will not be appropriate. Okay, the cosmetic result will be poor. So you do not reduce in edema, you reduce only when edema has subsided. Okay, right? So that is the correct answer to this question. Okay, now let us come to the zygomatic bone fracture. Now, zygomatic bone fracture is the second most common facial bone to undergo fracture, right? So fracture of the zygoma, it can happen because of the punch injury, because of the fall on the side. And what do we see in this fracture? We can see in this fracture that there are 3 fractures. Look at over here carefully. You can see that the zygomatico-frontal, right? You can also see that there is a fracture over here. That's a zygomatico-temporal fracture. Okay, and you can see that there is a fracture over here. So that's a zygomatico maxillary fracture. So you can see that there are 3 fractures. So therefore, this fracture was named as tripod fracture. Now, but if you look carefully in this photograph, you can see that with the development of CT scan, with the development of 3D imaging, we discovered that there is a 4th fracture. You can see that there is a fracture line which is going along the floor of the orbit. Now, because of this 4th line of fracture, we nowadays call it as quadripod fracture. So remember, students, this name has changed. Zygomatic bone fracture, which was earlier known as tripod fracture, is now renamed as quadripod fracture. There are actually 4 fracture lines, right? Okay, so you see, remember, there's another fracture line which is going in the floor of orbit over here, right? Now, how does this patient presents? So this patient presents, you see over here, there is a loss of this malar eminence. So this patient will present with history of trauma, and there is a loss of the malar eminence. Okay. Now, what will you find on examination? So you put your fingers over here and you will see that the 2 bones, they are not together, they are up and down. You see, the bones have fractured and now they are misaligned. So one bone is above and one is below, and you will see that there is a step formation. This is known as step deformity. Okay, so on examination you will find a step deformity. All right, now treatment. The treatment is you have to reduce it by open reduction. Open reduction and internal fixation. You have read this term a lot of times in orthopedics for the bony fracture reductions, which is known as ORIF, open reduction, internal fixation. So you have to give small incisions. Okay, so these are small cosmetic incisions which are given, and then you reduce these fractures with the help of K-wire and sometimes mini plates and screws. So you can give a sublabral incision, you give an incision in the eyebrow over here, and you can give an incision near the ear, and you can reduce this bone by giving these small incisions. Okay, so it's open reduction and internal fixation. Right, next we come to the fractures of the orbit. You see over here, suppose there is a blunt injury to the eyeball. So like a punch over here, you can see there is a blunt injury to the eyeball. Now what happens because of this blunt injury? The floor, you can see over here, the floor of the orbit, this floor of the orbit, this is the weakest wall of the orbit and it breaks. Okay, remember in the anatomy I told you that medial wall of orbit. So I'll remind you once again, medial wall of orbit, this is the thinnest wall of orbit. Okay, remember I told you that this is known as lamina papyracea. So suppose this is the medial wall, it is the thinnest wall. But on this lamina papyracea, a lot of ethmoidal cells are attached. Okay, so a lot of cells are attached. Now because of these cells, this wall may be the thinnest, but it is not the weakest. So which is the weakest wall? The weakest wall is the inferior wall, the floor of orbit. So remember this floor of orbit, it also forms the roof of maxillary sinus. So whenever there is a blunt injury like a ball hits the eyeball or the punch, now what will happen? Because of this force, the weakest wall, the floor, it breaks. Okay, so what happens? These contents of the orbit, they will hang in the maxillary sinus. Okay, so as you can see over here, these contents, the fat and the muscles, the extraocular muscles, they may hang in the maxillary sinus. So let's look over here. You can see over here, this is the inferior rectus muscle and there is a bony fracture. So what happens to this inferior rectus muscle? This muscle along with the other tissue, okay, the fat, it may come down, and when the bone tries to heal back, it gets entrapped. So you see the inferior rectus muscle, it gets entrapped in the bone. All right, as a result, what will happen? The patient is not able to move the eyeball. So you can see over here, this is the normal eye, patient is able to move. On the entrapped side, the patient is not able to move the eyeball. How can we check that this entrapment, this non-movement of the eyeball and the resultant diplopia is because of entrapment of inferior rectus? It may also be a nerve damage. Maybe because of trauma, there is a nerve damage, there is a neurological problem, and now the muscle is not moving. So how can we check that? We can check that with the help of a test which is known as forced duction test. Okay, so what do you do in forced duction test? You anesthetize the eyeball, okay, and on the conjunctiva, you give a local anesthesia, a few drops, and it will anesthetize the eyeball. And then what you do it, you hold it with the forceps and you move it. Okay, so when you move it forcefully, you will see that it is not moving. That is because of entrapment of the muscle. All right, so look over here. So this is the patient, you hold it, hold the conjunctiva and you try to move it. So it is not moving means it's entrapped. The muscle is entrapped. Right, now you can confirm this with the help of imaging also, and this was the earlier imaging. We used to do an X-ray. Okay, nowadays we do CT scan and you can clearly see that the orbital contents, they are hanging in the maxillary sinus. Right, this is known as teardrop sign. Right, teardrop sign. Now what treatment will you offer to this patient? Okay, this patient has presented to you with diplopia. If it is entrapped, there may also be enophthalmos. You see, the contents have hanged down, so the eyeball has gone in. There is enophthalmos. So what treatment will you offer to this patient? For this treatment, you have to repair the orbital floor. Now, repairing the orbital floor can be done in different ways. Okay, suppose there is an ENT surgeon, he will do a Cardwell lux and he will go from below, he can put a cartilage and he can push the contents up, put the cartilage and support the orbital floor. Okay, instead of cartilage, you can also put bone. Now, otherwise, you can also put a titanium mesh. All right. Now, an ophthalmologist, we give an incision over here. So that's a subciliary incision which they give, and then they will lift the eyeball along with the periosteum. And when they lift the periosteum, the bony fracture is visible. So all the contents are once again put back in the orbital cavity, and then the floor is repaired. Okay, so you can see over here, so that's a subperiosteal dissection being done by an ophthalmologist. So he'll lift the eyeball along with the periosteum, and then he can place a preformed orbital implant, that's a titanium mesh, or you can even put bone or cartilage to repair the floor, right? So there are different options in which you can repair the orbital floor. Let's come to this question. A patient presented after RTA, RTA means road traffic accident, with left-sided epistaxis and diplopia. So there is an injury to the face and nose, there is epistaxis, there is diplopia. Diplopia means eye is involved. Okay, on performing CT scan, following finding is reported. Let's look at this CT scan. So we can see that there is a teardrop sign. What would be the cause of diplopia? So you see, this question was asked in the NEET PG January 2019. They did not talk much about this test, but this image was given, and you can see that this is a force reduction test being done. So you can see a force reduction test, you can see a teardrop sign. This is a blowout fracture, clear cut fracture of the inferior wall of orbit. So answer was blowout fracture of the eyeball, right? Okay, let's come to the fractures of the maxilla. Now, fractures of the maxilla, they are known as Lee-Foot fractures. These Lee-Foot fractures are classified into three types: Lee-Foot 1, 2 and 3, right? So maxillary fractures, we will discuss these fractures. Now let us talk about Lee-Foot 1 fracture. What do you see in this Lee-Foot 1 fracture? So you can see over here, this is a Lee-Foot 1 fracture. Now the fracture line you see is parallel to heart palate, right? You can see this fracture line is parallel to heart palate. So this is a transverse fracture. We also call it as a transverse fracture. And what will happen? Because of this, we'll have a floating palate. So palate is free. The heart palate you can see is free. So this is known as a floating palate, right? Now, let's look over here, Lee-Foot 2. What do you see in Lee-Foot 2? This Lee-Foot 2, you can see this is a pyramidal fracture. Okay, so you can see that this is a pyramidal fracture. Now, because it's a pyramidal fracture, the whole maxilla has become free. So what you will find is a floating maxilla. The whole maxilla is free. You will find a floating maxilla over here. Okay, and let's look at the Lee-Foot 3 fracture. Now you see the Lee-Foot 3 fracture. This fracture is between the cranial cavity and the facial skeleton. So this is known as craniofacial disjunction. The whole cranial cavity gets separated from the facial skeleton. So it's known as craniofacial disjunction. Now remember, this is the most severe type of Lee-Foot fracture. Okay, why? Because it has maximum morbidity and mortality. Maximum morbidity. Why? You see, lot of cranial nerves which are coming from the skull base, they will get damaged. So lot of cranial nerve damage in this type of fracture, right? Now what happens? You see, let's say this is the facial skeleton and we have the cranial cavity over here. It's attached like this. Now when there is a fracture, when this thing has broken, cranial cavity, it will go inside, and when it goes inside, you see the facial skeleton, it rotates and protrudes forward. So when it rotates and protrudes forward, it gives a deformity to the face. The lower part is protruding forward. It is known as pig snout deformity. So Leaford 3 fracture has a pig snout deformity. Okay, remember both Leaford 2 and Leaford 3. Leaford 2 and Leaford 3, both of them, they are near the skull base. Both of them can even have CSF rhinorrhea. Okay, so CSF rhinorrhea we will discuss in the next topic. So remember, both these type of fractures can have CSF rhinorrhea. Okay, treatment. Now for all the 3, Leaford 1, 2 and 3, you have to do ORIF. ORIF means open reduction and internal fixation. Okay, so remember, you may have to do plating. Also the occlusion, the dental occlusion has to be taken care of. So you may have to put the dental arches, and you may have to properly make sure that the dental occlusion is all right. Okay.